Hey guys, so sorry I haven't posted in a while. It's not because I haven't been studying, it's in fact because I've been studying a lot and I've just been catching up a lot that I just didn't feel like I had the time to make a video. So I'm really sorry about that. But anyway, there's a trend going on around YouTube right now which is called the 100 Layers Challenge. So it's basically people putting on like 100 layers of anything, 100 layers of pants, 100 layers of shirts, 100 layers of foundation, 100 layers of fake eyelashes, 100 layers of everything. So since I haven't updated you guys on what I've been learning recently, I just thought it would be cool to do a 100 layers of knowledge on what I've been learning. This is obviously going to take a while, so I'll try to speak as quickly as possible. In 3, 2, 1, let the learning begin! Parasitic infections can turn you into an elephant. Just kidding, they'll only make you look like an elephant. So this is one of those things I cannot believe came without a picture in a textbook. I mean, looking like an elephant is so like, what? And so out there, how can you not put a picture of it? So the major type of elephantiasis that I've been learning about is called filariasis, which is an infection caused by filarial worms, which are tissue-dwelling nematodes. And there are two types, which are lymphatic and non-lymphatic. Lymphatic filariasis is spread by female mosquitoes, only the female bites. In sub-Saharan Africa and Southeast Asia, the worms that actually cause the disease are called Wuchereria bancrofti and Brugia malai. These worms infect the lymph nodes and cause obstruction to the lymph flow, which causes lymphedema. Gradual lymph node enlargement, coarsening, corrugation, fissuring, and secondary bacterial skin and subcutaneous tissue infection lead the skin to look like that of an elephant. The filarial worm Wuchereria bancrofti only shows up at the peripheral blood at night, and this is important because the diagnosis of filariasis is made by the detection of microfilaria in the peripheral blood. Now, the reason for this is largely unclear. Some say the physiological changes that occur during sleep, such as low body temperature and low oxygen tension, could act as signaling changes for the worm, but who knows? But we are certain that it corresponds with sleep, in that if someone sleeps by day and is awake at night, this periodicity would be reversed and the microfilaria would be detectable at morning only. The treatment of filariasis is with diethylcarbamazine. Non-lymphatic filariasis, also known as river blindness, is caused by the filarial worm Onchocerca volvulus and is commonly found in Central and Western Africa as well as Central and Southern America. It is spread by the female blackfly. Seriously, only the female bites. Diagnosis is again by detection of microfilariae, but this time on skin shavings or skin nips taken from corneal scleral punches or from scalpel blades from either the calf, buttock, or shoulder. Sounds fun. You can also detect filarial antibodies, but if these tests are negative, you can perform the provocative Mazzalti test, which means administering diethylcarbamazine, and if symptoms are exacerbated, it is more likely to be onchocerciasis. Because remember, diethylcarbamazine is used to treat lymphatic filariasis, but it is not used to treat non-lymphatic filariasis. In fact, it will exacerbate symptoms. So if symptoms improve with diethylcarbamazine, it is lymphatic filariasis, and if the symptoms are exacerbated, it is non-lymphatic filariasis. Non-lymphatic filariasis is treated with ivermectin. Silicates absorbed from volcanic soil is a non-filarial cause of elephantiasis. When I was little, my mom used to tell me the story of people pulling longworms out of people's bodies and remind me to take antiparasitic medications, and I would always take them without really knowing what was happening. Now I know it was probably Ascaris lumbricoides, which is a roundworm that hatches in the duodenum, migrates up the bronchial tree, and then is swallowed and ends up in the small intestine, where it can potentially cause intestinal obstruction. The diagnosis can be made from detection of ova and the feces, and of course the expulsion of roundworms from the rectum or the mouth. For the record, this was also not featured as a picture in the textbook. Treatment is with albendazole, mebendazole, and ivermectin, so take your parasitic medications, guys. You know what my favorite thing to eat in the world is? Chocolate. I love chocolate. I could eat it all day. But you know the one time I don't feel like eating chocolate is? When it's used to describe the grossest thing in the world. So did you know that Entamoeba histolytica causes liver abscess? Well, now you know. Now, the aspirated pus from the abscess caused by Entamoeba histolytica has been described as having a chocolate brown appearance. And this actually came with a picture in the textbook, and that's not chocolate! Hey, any of you speak Indian? No, you don't. The official language of India is Hindi. Anyway, I don't speak Hindi myself, but I recently learned one word in Hindi which is Kala Azar, which means visceral leishmaniasis. The literal translation for Kala Azar is black fever, and is referring to the fact that visceral leishmaniasis's clinical manifestation is blackish discoloration of the skin. Now, this is rarely seen nowadays, but clinical features that are more commonly seen in visceral leishmaniasis include high fever, chills and rigor, decrease in fever, relapse of fever, massive splenomegaly, moderate hepatomegaly, splenomegaly, and pancytopenia. Other than visceral leishmaniasis, there are two other types of leishmaniasis, which are cutaneous and mucosal. Cutaneous leishmaniasis is characterized by the development of a papule, which later ulceration is typically at the site of the bite. Oh, did I forget to mention that leishmaniasis is transmitted by sandflies? And guess what? Only the female bites. Mucosal leishmaniasis is characterized by the reddening and thickening of the nasal mucosa, typically between the upper lip and the nose, and ulceration later. Leishmaniasis can be diagnosed by the identification of a mastigotes, which are protists without flagella or cilia, by doing a Giemsa stain on an obtained specimen. In visceral leishmaniasis, that is the splenic aspirate. In cutaneous leishmaniasis, that is the slit skin. In mucosal leishmaniasis, you do a different test altogether, which is called the leishmanian skin test, which is an intradermal injection of killed leishmania organisms to see if there's a delayed hypersensitivity reaction. So in 48 hours, if there's a greater than 5 millimeter induration, the test is positive. Generally agreed upon that leishmaniasis can be treated with antimony compounds, though there seems to be some level of dispute on what to use to treat visceral leishmaniasis. English-speaking countries use sodium stibogluconate, and French-speaking countries use meglumine antimoniate. Kind of makes me wonder what Quebec uses. Cutaneous and mucosal leishmaniasis is treated with parenteral antimony. Now, there are many different types of fevers. We just talked about Cala-Azar, the black fever. There's also Lassa fever, typhoid fever, Cuban fever, yellow fever. No. Not your sexual affinity towards Asians, okay? The real viral hemorrhagic fever. I actually once heard the story of a patient who walked in and the doctor, who was Asian, asked the patient, "Oh, how are you doing today?" And the patient answered, "I have yellow fever." And I actually thought he was talking about the real thing too. Anyway, yellow fever is caused by a flavivirus and is self-limiting most of the time, but about 15% of patients enter a second acute phase of liver toxicity and hemorrhage, particularly vomiting blood. The Spanish actually call it vomito negro, which means black vomit. Also, if you have yellow fever, you should get away from me because all patients with yellow fever have to be isolated. Thankfully, there's a live attenuated vaccine. When I was a young student, I dreamed that I would one day become a doctor and join Doctors Without Borders. Is it just me? Anyway, I watched a documentary on Doctors Without Borders, and in it there was the scene where the doctor says,
"It can be Lassa fever, it can be yellow fever,"
which is how I learned about yellow fever in the first place. But anyway, let's talk about Lassa fever. It's spread by rodents, it's common in West Africa, and the symptoms of retrosternal pain, proteinuria, and pharyngitis have a positive predictive value of 80% in West Africa. Because this is a viral hemorrhagic fever and it is common in West Africa, people have a tendency to mistake this for Ebola fever. However, Ebola fever has a mortality of up to 70%, while Lassa fever has a mortality of less than 1% because it is treatable. Treatment is with ribavirin. However, if the AST level is greater than 150, the mortality rises to 50%. Let's talk about another type of fever, for example, the spotted fever, which has many different subtypes. For example, the Rocky Mountain spotted fever, which causes a maculopapular eruption in 1 to 2 days, or the spotless spotted fever? Another type of fever, the glandular fever, aka infectious mononucleosis, aka Kissing's disease. Okay, this is just an advice for medical students out there. You have to know all the alternate name for all the different diseases, because if you know the answer but you just didn't get the answer because you didn't know that that disease was just an alternate name for the one that you knew, that just sucks. Anyway, I used to think infectious mononucleosis was only caused by the Epstein-Barr virus, but I was wrong. It could also be caused by the cytomegalovirus, the human immunodeficiency virus, the human herpes virus 6 and 7, and also toxoplasmosis. An allergic skin reaction to ampicillin or amoxicillin is a typical feature of infectious mononucleosis. This is problematic because infectious mononucleosis is typically mistaken for strep pharyngitis because severe pharyngitis is also a typical feature of infectious mononucleosis, and when patients are prescribed ampicillin or amoxicillin, they will get a skin reaction. You can differentiate between strep pharyngitis and infectious mononucleosis because infectious mononucleosis, being a glandular fever, will have glandular involvement. They will have cervical or inguinal or axillary lymphadenopathy or splenomegaly. There are 4 serotypes of the dengue virus. If you have had dengue fever before and you have recovered, you will have lifelong immunity towards the specific dengue virus serotype that you have had, but you will only have immunity towards the other serotypes for about a few months. This is a problem because if someone who is immune to one serotype of virus is then infected with another, this will trigger a more severe form of dengue fever, such as the dengue hemorrhagic fever or the dengue shock syndrome even, because prior immunity results in increased viral uptake and increased T-cell activation, which leads to increased cytokine release, which leads to capillary leakage, which may even result in disseminated intravascular coagulopathy. African trypanosomiasis, otherwise known as sleeping sickness, is caused by Trypanosoma brucei, gabiense, and robiense, in which robiense causes more severe, more acute disease. It's transmitted by the tsetse flies who bites are painful, and 10 days later the bite sites become painful again and swollen, and this is called the development of the trypanosomal canker. The regional lymph nodes become swollen as well, and this is called the Winterbottom sign. Diagnosis is by the identification of antibodies, and the test is known as the cardiac agglutination trypanosomiasis test. For gabiense infection, the first line treatment for the first stage is pentamidin, and the second line treatment for the first stage is melarsoprol. First line treatment for the second stage is eflornithine, and the second line treatment for the second stage is melarsoprol. For rhodiense infection, the first line treatment for the first stage is ceramin, and the second line treatment for the first stage is melarsoprol. First line treatment for the second stage is melarsoprol, and the second line treatment for the second stage is nifurtimox plus melarsoprol. American trypanosomiasis, otherwise known as Chagas disease, is caused by Trypanosoma cruzi and is commonly found in Southern and Central America and most commonly affects children. Now, it has an acute form and a chronic form, and the chronic form is more common, about 50 to 70%, and can cause myocarditis. But here's the weird thing. In chronic forms, it can be diagnosed by having reduvic bugs actually feed on the patient and then examining the feces of the reduvic bugs. Oh no, get away from me. This is called xenodiagnosis. Is it accurate? No, it only has about 50% accuracy, and we don't even use it anymore. We use parasitic DNA detection by polymerase chain reaction. Prescribe or to not prescribe antibiotics? That is the question. And we should all know by now that for viral illnesses, antibiotics are absolutely of no benefit. But what about for bloody diarrhea? Bloody diarrhea is often caused by bacteria, and it can be caused by enterohemorrhagic E. coli, or it can be caused by Shigella, among other different causes. But for enterohemorrhagic E. coli, if you give antibiotics, you increase the risk of hemolytic uremic syndrome. But for Shigellosis, antibiotics are absolutely indicated. So, what about Borrelia infections? Antibiotics are usually indicated, but for Laos-borne relapsing fever caused by Borrelia recurrentis, successful therapy by antibiotics are usually followed by Joris-Herxheimer reaction, which is basically like a septic shock reaction. Yeah, no big deal. To use pads or tampons, that's not a question, just use pads. The use of highly absorbent intravaginal tampons have been associated with staphylococcal toxic shock syndrome. If you like to cook things at home and store things in jars, beware. Improper hygiene and home-cooked foods have been associated with botulism poisoning. Yeah, the Botox poisoning. Yeah. Medically important schistosoma species are Hematobium mansoni and Japonicum. Katayama fever is acute schistosomiasis, and it is most commonly associated with Schistosoma japonicum. Schistosoma mansoni infection predisposes to Salmonella carriage. Medically important Bartonella species include Quintana, which causes trench fever, and Hensley, which causes Castratus disease. Both cause endocarditis and also bacillary angiomatosis, and are treated with chloramphenicals or quinolins in adults and with beta-lactams in children. If I could get serious for a second, I just want to talk about a disease that is more important on a legacy level than a medical practice level, and it's caused by Bartonella bacilliformis. It causes an acute form of a disease called Oroya fever, and it also causes a chronic disease called Verruga perorana. Now, in the 19th century, when not much was known about this disease, there was a medical student called Daniel Corian who wanted to prove that Oroya fever and Verruga perorana had the same etiological agent, and he inoculated himself with lesions from a patient, and he developed the classical symptoms for diseases, and actually the experiment proved to be fatal and he passed away. It was only after about 35 years that his hypothesis was shown to be true, and he is now recognized as a medical martyr. I just wanted to take this opportunity to recognize when I talk about a disease, I say a lot of things about it, right? It's caused by this, and it's transmitted by this, and this is how it's diagnosed, and this is how it's treated. But I just wanted to recognize that every step of the way, every fact that we know now, it came from the sacrifices and the suffering from those who came before us, and I just wanted to pay homage to that and be really grateful for people who, sacrificed themselves for medical research. And I think it's important to be thankful for those who came before, so we could also help people who will come in the future. Medically important Borrelia species include Burgdorferi, which causes Lyme disease, Recurrentis, which causes louse-borne relapsing fever, and Dutani, which causes tick-borne relapsing fever. Lyme disease is treated with doxycycline, and louse and tick-borne relapsing fevers are treated with tetracycline. Wait, Lyme disease is treated with doxycycline, but the relapsing fevers are treated with tetracycline? Isn't doxycycline a type of tetracycline? As it turns out, tetracycline is both a class of antibiotics, but also a specific type of antibiotic that belongs to the class of tetracyclines. So the tetracycline that is used to treat the relapsing fevers is a specific type of antibiotic, and it is different from doxycycline, although they both belong to the same class of antibiotics. The diagnosis of toxoplasmosis is with the Sabin-Feldman dye test, which is an indirect immunofluorescence test that detects IgG antibodies. Medically important brucellosis species are Melitensis, which is from sheep, goats, and camels, Abortus, which is from cattle, Swiss, which is from pigs, Canis, which is from dogs, and is treated with a combination of rifampicin, gentamicin, and doxycycline. Medically important Shigella species are Dysentery, Flexneri, Boydii, and Sony, and is treated with ciprofloxacin. There are three types of typhus: scrub typhus, which is caused by Orientia tsutsugamushi and transmitted by mites; epidemic typhus, which is caused by Rickettsia prowazaki and transmitted by louse; and endemic typhus, which is caused by Rickettsia typhi and transmitted by fleas and is treated by tetracycline. Q fever, caused by Coxiella burnetii, has antigenic variation. Phase 1 is very infectious, and Phase 2 is not very infectious and is treated with doxycycline. Okay, let me just take these off. These are getting really painful. Canoes and windsurfers are prone to leptospirosis, which is caused by Leptospira interrogans. 10% will go on to develop Wheels disease, which is icteric leptospirosis and characterized by fever, hemorrhage, jaundice, and renal impairment. Diagnosis is with microscopic agglutination tests, but IgM, ELISA, and immunofluorescence tests are more convenient and is treated with doxycycline. Most cases of salmonellosis does not require antibiotics, but typhoid fever requires treatment with ciprofloxacin. The plague is caused by Yersinia pestis, and there are three types: bubonic, which is the commonest, septicemic, and pneumonic, and it is treated with aminoglycosides. Yersinia enterocolytica can cause gastroenteritis after ingestion of uncooked pork, but may also cause mesenteric adenitis. Anthrax is caused by Bacillus anthracis, and there are three forms: cutaneous, gastrointestinal, and inhalational, and it is treated with ciprofloxacin until penicillin susceptibility is confirmed. Listeriosis occurs as a result of food contamination after ingestion of raw vegetables or uncooked meat. It demonstrates cold enrichment in which it outgrows other contaminating bacteria during refrigeration. It is treated with aminoglycoside plus aminopenicillin, and cephalosporins are useless. Giardia attaches to the duodenal and jejunal mucosa, so often diagnosis is made by endoscopic aspiration of the duodenum and jejunum, but there's also this thing called the string test, which makes sure you swallow a string and make sure it goes to the duodenum, and then it's just retrieved like that, and it's tested for Giardia. My microbiology professor used to say, if you eat seafood and get sick, don't look at me for sympathy, and sadly I have to admit that he may be right. Bivalve clams such as oysters, scallops, and mussels can lead to paralytic shellfish poisoning and also hepatitis A. But I would like to point out you can't get vaccinated for hepatitis A. For central venous catheter infections, the infection rate is higher for temporary catheters inserted into the groin or the jugular vein than into the subclavian vein. Up to 40% of acute disseminated candidiasis will have ophthalmic involvement with characteristic cotton wool exudates. Treatment of systemic candidiasis is with echinocandin initially, and then with IV or oral fluconazole. I just thought that was interesting because all other fungal infections seem to be treated with itraconazole. Immune reconstitution inflammation syndrome, IRIS, is a very curious phenomenon in which better immune system actually leads to worsening disease condition, and this is particularly of note in HIV infection or tuberculosis. Most fungal infections, especially severe ones, affect immunocompromised hosts. However, Cryptococcus gattii causes severe disease, especially in immunocompetent hosts. Histoplasmosis can be easily confused with tuberculosis because they both show respiratory and constitutional symptoms, and they both affect immunocompromised hosts. Fusarium species causes disseminated disease in patients with prolonged or profound neutropenia. It causes antibiotic-resistant fever, and it itself is resistant to several antifungals. It is treated with voriconazole, posaconazole, and lipid-formulated amphotericin B. Hyantid disease is caused by Echinococcus granulosus, and dogs are common hosts. It is a cause of multiple cysts in the liver. It's actually kind of pretty if you forget that it's a disease. Chlonorchis sinensis can be diagnosed by the detection of ova in either the feces or the duodenal aspirate. Loeffler syndrome is pulmonary eosinophilia, and it is most commonly caused by parasitic infections by Escherichia lumbricoides, Strongyloides stercoralis, and Ancylostoma duodenale. Ancylostoma duodenale are the original vampires. They literally attach themselves to the mucosa of small intestines and suck blood from you relentlessly every day. I mean, look at those teeth! Let's be honest, I weren't calling on nothing on Ancylostoma duodenale. After centrifugation of blood, it is separated into the plasma on top and also red blood cells at the bottom, and the middle layer is called the Buffy coat. And the quantitative Buffy coat can be used to diagnose parasitic infections, including leishmaniasis and malaria. The pattern of transplant-related infections really depend on the timing. First, there's the bacterial or fungal infections related to the actual disease, and for solid organ transplants, this is 1 month post-transplant, and for HSCT, this is 1 month pre-transplant. Then there's opportunistic infections like cytomegalovirus or pneumocystis jirovecii, and for solid organ transplants, this is 1 to 6 months post-transplant, and for HSCT patients, this is within 100 days post-transplant. Finally, there's post-transplant lymphoproliferative disease, shingles, or community-acquired pneumonia, and for solid organ transplants, this is after 6 months post-transplant, and for HSCT, this is after 100 days post-transplant. Other than Treponema pallidum, which causes syphilis, other treponematosis include yaws, Bidgel, and Pinta. Tularemia is caused by Francisella tularensis and is highly infectious. Diagnosis is by either a single high titer of greater than 160 or a 4-fold increase in the tularemia tuberglutination test, and the treatment is with aminoglycosides. You know how disease caused by salmonella is called salmonellosis? Disease caused by Shigella is called shigellosis? You know what we call a disease caused by Burkholderia pseudomallei? Melioidosis? Wait, what? Anyway, it can present decades after exposure to rice paddies, and it is treated with ceftazidime with maintenance cotrimoxazole and doxycycline. About 70% of leprosy patients live in India. Leprosy is on a scale of no cell-mediated immunity to high cell-mediated immunity, and from here to here, there's lepromatous, borderline tuberculoid, and tuberculoid. Tuberculoid leprosy is paucibacillary on Schwann cells, and lepromatous leprosy is multibacillary on Schwann cells. Tuberculoid leprosy has single lesions that are well defined with anesthesia, but lepromatous leprosy has multiple widespread nodules with infiltrations. Tuberculoid leprosy has better prognosis than lepromatous leprosy. Plasmodium falciparum, which causes malaria, not only does not grow well in sickle cell anemia, it also does not grow well with hemoglobin F or hemoglobin C. Preventing malaria is all about using a mosquito repellent with high diethyl toluamide, and electronic mosquito repellents do not work. And also you should use insecticide-treated bed nets with permethrin. Alright, so that's a wrap for Chapter 13, Infectious Diseases, and now moving on to Chapter 14, which is HIV and AIDS, so let's get into it. HIV is clinically staged into 4 stages by the WHO and into categories A, B, and C by the CDC. Stage 1, or Category A, is basically asymptomatic with generalized persistent lymphadenopathy. Stages 2 and 3, or Category B, is characterized by things like constitutional symptoms, candidiasis, herpes zoster, oral hairy leukoplakia. Stage 4, or Category C, is basically AIDS, with all of the AIDS-defining conditions. HIV has 2 subtypes. HIV-1 is responsible for the global pandemic, and HIV-2 progresses much more slowly, but it is limited only to West Africa. HIV-1 is further divided into 3 types: the M type, which is the major type with worldwide distribution, the O type, which is the outlier type, and the N type, which is the non-major, non-outlier type. The types N and type O are also only limited to Western Africa, so it's mainly just type M. Now, type M is further divided into types A, B, C, D, F, G, H, J, K, and type C is responsible for about half of the HIV cases. As of 2014, there are about 36.9 million people globally infected with HIV, which is greater than the entire population of Canada. The major route of HIV transmission is heterosexual. A one-time sexual exposure to HIV does not mean that you now have HIV. In fact, the HIV transmission rate from a single sexual exposure is very very low, ranging from 0.005% to 0.5%. Compare that to 90% from blood transfusion. However, the rate of HIV transmission is increased by concomitant STD infection with genital laceration, uncircumcised penis, or through menstruation, so don't have sex on your period. If the mother is infected with HIV, the risk of mother-to-child HIV transmission is 15%. This is how HIV enters the CD4 helper cells. GP120, which is a glycoprotein on the virus, binds to the CD4 receptors, which causes a conformational change in the GP120, which allows us to bind to CXCR4 or CCR5. This is shortly followed by membrane fusion and cellular entry involving GP41, and I swear I am going somewhere with this. There's a genetic mutation called the CCR5 delta 32, and if you have 2 copies of it, you do not express CCR5 on your cells, which means HIV cannot enter, which means you are immune to HIV. Crazy! The CDC recommends universal HIV screening for all, not just for those at high risk, which is very strange for me because my country only screens, people of high risk. The CD4 helper cell count varies about 20% day by day. The median time for HIV-infected adults to progress from primary infection to AIDS is about 9 years. Lymphadenopathy in HIV-infected individuals can be caused by tuberculosis, which give fluctuant lymph nodes, or lymphoma or other malignancies, which give non-fluctuant lymph nodes, and inexperienced clinicians incorrectly perform incision and drainage sometimes, but the correct thing to do is to perform a needle aspiration and send for AFP smear and cytology, and if this is unhelpful, perform an excisional biopsy. HIV wasting syndrome is defined as a more than 10% loss in body weight combined with either chronic diarrhea for more than 1 month or chronic weakness and prolonged unexplained fever for more than 1 month. Pyrexia of unknown origin has 2 criteria. 1, persistent fever of over 38 degrees for at least 3 weeks, and 2, being without a diagnosis despite initial investigations in 3 days of inpatient care or 2 outpatient visits. A pathognomonic description of herpes zoster is a vesicular rash on an erythematous base in a dermatomal distribution. Mucocutaneous manifestations of HIV include aphthous ulcers, oral hairy leukoplakia, oropharyngeal candidiasis, gingivitis, seborrheic and Kaposi sarcoma. HIV infection is not only associated with more frequent, more severe infection, it is also associated with more frequent, more severe allergic reactions. Cutaneous hypersensitivity's frequency has increased up to 100 times in HIV-infected people, and this manifests most often in sulfonamides and non-nucleoside reverse transcriptase inhibitors. CMV colitis can be diagnosed by a typical finding of ALS-I inclusion bodies on ulcer biopsy. Mycobacterium avium complex causes watery diarrhea, but unlike cryptosporidiosis, isosporidiosis, and microsporidiosis, fever is a prominent feature. Several nucleotide reverse transcriptase inhibitors are also effective against HBV. I knew tenofovir is effective against HBV and HIV, but I guess I didn't put 2 and 2 together and think, oh, if an HIV infection has an HBV co-infection, you should probably give tenofovir. HIV cholangiopathy is a type of secondary sclerosing cholangitis. Pulmonary tuberculosis in patients with CD4 counts of less than 200 is very different from pulmonary tuberculosis in other patients. Sputum smears are typically negative, cavities are rare, and pulmonary infiltrates are generally not apical. However, hilar mediastinal lymphadenopathy and pleural effusion are common. Kaposi sarcoma often spreads to the lungs. I should have known that. I did not. I am a failure of a human being. There are 2 main types of cognitive impairments associated with HIV. 1, the HIV-associated neurocognitive disorder, HAND, or 2, progressive multifocal leukoencephalopathy, PML. HAND can be asymptomatic neurocognitive impairment, and this is the commonest. It can be minor neurocognitive impairment, or it can be HIV-associated dementia, also called HIV encephalopathy. PML causes stroke-like episodes and progressive cognitive impairment. It is a white matter inflammation caused by the JC virus, and there is currently no treatment available, and the prognosis is poor. The most common cause of space-occupying lesion in AIDS patients is toxoplasmosis, so we should always give a trial of pyrimethamine, sulfadiazine, and folinic acid while awaiting results. HIV is associated with an increased risk of myocardial infarction due to accelerated atherogenesis by inflammation. HIV-associated vasculopathy with occlusion can also cause a stroke. Even if both partners are infected with HIV, they should still wear condoms in order to prevent the transmission of more virulent organisms or organisms that have developed resistance towards antiretroviral drugs, and also prevent the transmission of herpes simplex virus. Cotrimoxazole is used for primary prophylaxis of PCP pneumonia, bacterial pneumonia, bacteremia, cerebral toxoplasmosis, isosporidiasis, and malaria. Antiretroviral therapy has increased the life expectancy of HIV-infected patients from 10 years to 50 years. Non-nucleotide reverse transcriptase inhibitors such as efavirenz and nevirapine have a low genetic barrier to resistance but are still used as first-line drugs because they are cheaper and better tolated. Protease inhibitors have a high genetic barrier for resistance and are used as second-line drugs. HLA-B5701 has a 100% negative predictive value for abacavir hypersensitivity. 100%, that's crazy! In babies of HIV-infected mothers, the HIV RNA has to be checked instead of HIV antibodies because they may have inherited maternal HIV antibodies which may persist up to 15 months. Even though HIV can be transmitted by breastfeeding, breastfeeding is still recommended in low-income countries because 1, antiretroviral therapy can reduce the transmission, and 2, formula feeding increases the infant mortality rate. Alright, that's a wrap for chapter 14. Now we move on to chapter 15, sexually transmitted infections. In men, first void urine rather than urethral swab is the specimen of choice when testing for gonorrhea and chlamydia. Primary syphilis is also called canker. Remember what I said about remembering alternative names? This also explains the name cancroid. Believe it or not, you can actually distinguish the cause of vaginal discharge by looking at its appearance. Frothy yellow or green is usually trichomoniasis, or white and curdy is suggestive of candidiasis. White and homogeneous is more suggestive of bacterial vaginosis. Curiously enough, bacterial vaginosis there is also no surrounding area of inflammation, while trichomoniasis and candidiasis have vulval and vaginal inflammation. Some antifungals used to treat vaginal candidiasis, such as clotrimazole and iconazole, actually damage latex condoms. Differential diagnoses of chronic vulval lesions include lichen planus and lichen sclerosus. Lichen planus usually are violet papules, and lichen sclerosus are usually ivory white plaques. Lichen planus usually do not require any treatment, maybe mild steroid treatments, but lichen sclerosus requires strong steroid treatments such as clobetasol. Benign tertiary syphilis's characteristic feature is a chronic granulomatous lesion called a gamma. It can occur on the skin or mucosal surfaces. Now, gammatus involvement of the tongue can heal into a leukoplakia, which is prone to malignant change. External HPV warts can be treated with podophylotoxin or imiquimod creams, although they are both contraindicated in pregnancy. Finally, done! Oh my gosh, so that was my 100 layers of infectious knowledge, you guys. That took so long. When I first started, I thought maybe I was taking the easier way out or something, but oh my gosh, no. It was bright when I started, and now it's like 2:30 a.m. in the morning. I hope you enjoyed watching the 100 layers of infectious knowledge thing, and I hope you've also learned something from it. This has definitely helped in my revision. Yeah, I enjoyed that, but oh my gosh, I'm tired. Thanks for tuning in, and see you next time. Bye.